Hello, and welcome to the Healthcare Executive Insights Podcast. My name is Elliot Sloan with the Macallan Group. Today, we have a very special guest, Farhad Chowdhury, the CEO and founder of Vianova AI. Farhad, thank you so much for joining us today. Please tell us a little bit about your professional background, and then we'll chat more about your company, Vianova AI.
Thank you for having me, Elliot. A little bit about me. I've been in tech for a long time. I'm a born and raised New York native. So born in the Bronx, raised in Queens. And I think that has a lot to do with my mindset. I started in tech in 2000, moved to DC, and I launched my first company in 2006. Then from there, I did a lot of government stuff, US Census, UK Census, worked at, Department of Interior, etc. Then I launched my second company. It's called Fifth Tribe. And we wanted to basically create like a PowerPoint killer off the iPad. And then one day I pitched it to the Department of Defense at the Pentagon. And at the time, there was a Deputy Assistant Secretary of Defense who was really like this cool, young, hip tech guy. I've never seen anything like him. Like this guy was just super impressive. So I pitch him and he's like, best demo I've seen this year. And I was like, cool. So I'm trying to sell it. And he goes to me, I'll give you a deal. I'll buy your product in the DoD, which is the contract of all contracts, but you got to build one small thing for me. So I was like, okay. So 3 years, I'm at the Pentagon after that. And I built a system in predictive analytics, got published, was doing some active secret clearance work, pretty cool. And I was like, okay, now it's been a decade in government and I'm done. Teamed up with two docs and launched Vianova Health, which was a pure health concentrated mission. And 6 months into it, I built this thing for my dad because his diabetes was out of control. So I needed a way to check on him remotely. And all of a sudden, after doing it for a while, his blood sugars got managed because I was checking on him every day. A CEO from Kaiser Permanente comes up to me and looks at it and goes, can I take it with me? And he takes the device with him back to Los Angeles. I was in DC at the time. And I get a phone call. Can you come down to LA? So I fly out to LA, pitched about 17 people. Next thing I know, we're starting to work with Kaiser Permanente and, in Los Angeles in the Valley with Spanish and English speaking patients. And boom, Vianova was off to the races at that point. So pretty interesting.
Wow.
Yeah.
Where did it grow from there?
So it was really interesting. Right out the gate, we were doing well. We were working with Kaiser. We got the second contract with Kaiser. We were able to show some really interesting data. We got to 82% daily engagement, which is crazy in the remote patient monitoring world. We increased medication adherence. We were showing impact on blood sugar levels, and things were rocking and rolling. Closed the second contract with Kaiser, and I actually teamed up at this point with Lenovo, and we met them at this massive conference called HIMSS, and they basically decide to select us. So we're the exclusive virtual care partner for Lenovo. There are 1,400 hospitals in the US. And we're just about to launch this massive, national campaign, and COVID hits. They cancel the conference that Friday. Our national launch gets shut down on Monday. Kaiser Permanente calls us and says, guess what? We're basically just trying to get through COVID. All contracts are on pause. And we literally are in can we survive mode. And we go through this crazy, difficult process and have to pivot very aggressively. So our initial product was biometric devices, blood sugar. We still have it, blood pressure, blood sugar, all these devices with the Bluetooth pairing to a tablet, which was an iPad and you would mail these kits to patients, or you'd hand deliver kits, and they would check it and it would immediately go to our call center dashboard or go to the doctor's app, and he could review all his patients. But with COVID, the concept of devices and device logistics was too hard. So we had to pivot. And in every iteration, it's like we've seen this massive change where even your senior citizen patients, they don't want two devices. They're using their smartphone. They know how to take pictures. They're starting to chat. So we started shifting away from these big, bulky devices and handing out tablets to making everything smartphone centric. And it's amazing to see in 5 years how much 75-year-olds have changed their digital behavior. It is just amazing, like way beyond expectation. So we're dealing with seniors, but now we're like, our platform opened up to multiple demographics. And so in around 2018, I go to the Stanford Behavior Design Labs I meet with Dr. BJ Fogg, who created the lab. And I decide me and my co-founder get certified in behavior change by him. And I realize remote patient monitoring and healthcare as a whole is not a device problem. It's not a medicine problem. Healthcare is a habit problem. Full stop. Meaning why they get sick and post sickness, post chronic disease, designation, post discharge, you have doctors literally, and I looked at thousands of what they're called as care plans, these plans you give out to patients. This is what you got to do at home. This is your treatment plan. They're all habits. Doctors prescribe habits, and I've sat down with 400 doctors now, and none of them have studied behavior change. They haven't studied habit, and they appreciate the fact that we do and that we speak to it. And they're like, I don't know, tell me how to do this. So then we shifted our entire platform from becoming a remote patient monitoring company. We are a behavior change company today. And it's all about habit formation. And it started with the work of Dr. Fogg. So then I went further and I got certified as a habit coach under Dr. Fogg's Tiny Habits. So I'm certified in 2 different areas within the space. And we are now like taking it to a whole other level. We can apply it to any vertical. It started in healthcare. We've applied it in education, and we've applied it to NGOs, to nonprofit organizations who are using it to improve behaviors with their volunteers, to improve their employees, to improve their members. We think we've come to the ability to figure out the pattern, to nudge people in the direction that's needed for to do habits at scale. So wow. I could geek out on this for hours, but I'll let you.
Feel free. There's a lot there. There's a lot there to unpack. So originally, you were sending packages with hardware where people were using your devices to do blood monitoring and other at-home diagnostic tests that was connecting to your application on an iPad that you would provide.
Correct. And then with Lenovo came along and said, hey, use our tablets. And we were like, cool. And they're like, we'll do all the shipping, the logistics, the kit assembly. We'll do all of that. You just focus on software. We were like, great. And we had we literally had boxes coming out the factory, logos, stamp, things, all of that. The amount of work that went into operationalizing these things were crazy. But we also saw the entire world shift.
Sure.
COVID and through, just digital behavior has changed.
So when you became more focused on the software that can be operated from a smartphone or mobile device, didn't that still require your application and your software to push and pull or to pull data from these at-home monitoring devices?
Yes and no. So what's interesting is like you start giving out these devices, and after a while, in some cases, we'd give out devices and the patients are like, I don't want to change my device.
I already
use this blood pressure cuff. I already use this glucometer, whatever. And then on top of that, we started working with insurance companies. And insurance companies like, we already gave out 300 of these things. They don't have Bluetooth, they don't have cellular, but we don't want to start giving out more. Or I'll give you them like a very complicated problem. Insurance company or Medicare or whatever already gives out specific lancets and strips for certain glucometers. You can't start introducing new, even if we fulfill all the criteria we did and regulatory boards. Now you have to deal with that set of logistics. So customer A has a contract with this company and you're always shifting and they're not Bluetooth devices. So we sat there and said, you know what? We need to not worry about that. We need to still capture that data and make sure it's solid and it's truly them. But how do we do it smarter? And like I said, remote patient monitoring is not a device problem. It's a habit problem. Healthcare is a habit problem. All these RPM, remote patient monitoring, chronic care management companies, when you sit with the nurses and you sit with the medical assistant, you talk to them, they will tell you how hard it is to get a patient to start and to get a patient to stick. It is like death. And so you can sit there and talk to me about devices till you're blue in the face. How many of us have tried a Fitbit? How many of us have tried the watches? And how many of us have stuck to them regularly? I mean, you're talking about younger generations. So we today have simplified the hell out of it. And I just want to say one thing, like if you study James Clear Atomic Habits, if you really pay attention, James Clear got the core concept from BJ Fogg. And he says that in the beginning of the book. The godfather of habit I think 20 years from now, we're going to be like the Carl Jung or the Nietzsche of habit, or not, sorry, like the great leaders of habit. They're going to say it's going to be Dr. Fogg. So I don't want to take
Wow.
anything away from Dr. Fogg. And you watch his TED Talks, he'll blow, his book's amazing. I'm going to give him his flowers. And I don't think he gets his flowers enough, even though he's a killer. He's amazing. The world loves celebrates him. But the core of it is simplicity and habit are directly correlated.
Micro habits.
Exactly. So that's where atomic habits come from,
Yeah,
right?
I know the book. I've read it.
So how do you make it super simple? And so today, our core is picture points rewards. So we have the patient simply take a picture of their meds, or take a picture of their vitals, or take a picture of their meals, or take a picture of their movement. And if you paid attention there, we call that the 4 M's: meds, meals, movement, monitors. Monitors being vitals. If you want to manage a patient, you just got to build habits around the 4 M's. And honestly, even if you do it once a day for 3 minutes a day, you've made massive progress. So all we concentrate on today is the 4 M's. That's our core. And then we have additional stuff. And we get the patients hooked within those 3 minutes a day, 2 minutes a day, to simply just think about how simple it is to a patient. Just take a picture. And then boom, they see the points go off. And the dopaminergic effects to play with points is a whole other thing. Because as atomic habits, or as BJ Fogg will say, you must immediately celebrate the patient after they do what they're supposed to do. What's simpler? And I'm going to ask the question, what's simpler than a picture? Nothing. So that's my argument out there. And you want to make the habit under 30 seconds, under a minute. So the idea of them having to use, your device, get the device to them, they have to pair the device, or they sell you. Oh my goodness. Take a picture of your pills like this. Just take a picture of your vitals like that. Just take a picture of your breakfast, and you don't think after that.
Wow.
And, yeah. So I could go deeper into this, but again.
So that is what you're determining is the average commitment per patient that is using your habit forming technology is about a 3-minute commitment on a daily basis.
3 minutes, and it's either mornings or evenings is the focus, right? One habit per day, start there. That's it.
Which is just uploading a photo when you take your medicine.
Either you put your pills in your hand, or you put the pills on the table and you go like this, boom, you take a picture. And immediately it goes to the coach. So you see your points pop up, 15 points. You know that your coach reviewed it. Now I'm looking at multiple drivers to move people. One driver are the points, the celebration. The other driver is the social element. There's someone watching, and and then we have a chat. So the coach immediately could be like, great, 3rd day in a row. Great, I gave you 15 points. Oh, I'm giving you additional coach points, right? Because there's an element of surprise helps. And then the third is we make it optional today. We provide rewards. So what does that mean? After 1,000 points, or after your month of whatever, we work with our clients and say, do you want to give out a gift card? Do you want to give out, and we have like 80 different companies, from Walmart to Nike to Adidas to Target to whatever you want. So is it worth it to give a patient a $10 gift card? Especially, okay, you're dealing with the patient, and his single pill or her single pill is worth $30. Is it worth $10 or a $20 gift card?
I guarantee the insurance companies would be cutting those gift cards all day long if they're able to help prevent illnesses down the road.
That's exactly it.
The way you propose it, of healthcare being a habitual problem and not necessarily a device problem, it makes a lot of sense the way you phrase it like that. Unfortunately, most people have a lot of habits, but they're bad habits. They're bad habits for their health. If they could tweak some of those habits to be more of preventative measures to their long-term health, then everyone wins across the board: the providers, the patients, the insurance companies.
Correct. Absolutely. And like I said, it's amazing to come down to these 4 M's, right? Every doctor just cares about 2 things, or 90% of doctors care about 2 things. They care about the monitors and the meds, because it's like they could manage those 2. They look at your blood sugar like they look at the odometer and the speedometer, and then they fine tune it with medication. The hard part is the meals and the movement. That's the challenge for a lot of people, other two M's. So again, you start at the tiniest beginning. Are you even aware of what you're eating? Do you at least put your sneakers on to walk? Just start there. I heard a quote the other day, it was phenomenal. It said the heaviest weight at the gym is the front door, right? I think what we as Vianova, we want to be great in the world at one thing today, at this moment. The best company in the world at starting.
Tell me about who is currently using your technology for building better habits for their patients.
So we're working all over, a number of different kind of combination of organizations, where they could be primary care offices, endocrinologists. You're working with hospital systems, small little insurance players. And what we're right now trying to close our first set of these are self-insured employers, right? That's another huge market that we're starting to tap into. So today, what Vianova is really focusing on is transitional care. We're not only doing chronic care and remote patient monitoring, but if you want to get the greatest impact on medical economics, on the cost of healthcare, there's two data points. It's the length of stay, how many days someone stays in the hospital.
Yep.
And two, it's those 30 days
after.
And so what we're doing now is reducing the length of stay and reducing readmissions.
Wow.
By building these habits. And we're hyper focused because what's the hardest part about transitional care? The start.
So what type of patients are you seeing your technology being most useful for, as far as them while they're in the hospital and then the 30 days after? Are we talking elective surgeries, or are we talking a certain type of condition that you seem to find the best use case?
Well, we went after kind of like the 800-pound gorilla. So the majority of your patients are going to come out with, they're going to be diabetics, they're going to have CHF, high blood pressure, hypertension. So we kept going after our four major chronics, right? COPD, CHF, hypertension, diabetes, right? We always go after that. And then, of course, we allow a lot of flexibility for our providers to simply add one or two behaviors that they want to manage on top. So as an example, let's say they want the patient to score their pain, or they want the patient to take a picture of their wound, right? Or if they want to have the patient, as an example, show that they're doing one of those physical therapy exercises. So for our platform to send a portrait video of a physical therapy exercise we do that today. And then to have the patient take a picture of them standing up and just showing the beginning of the exercise, for us that's enough.
I'm thinking this could be a very effective tool for other specialties like bariatric surgeries. There's so much that happens with a patient after a weight loss journey, with the course of care that needs to take place for them to actually be successful with weight loss, or if it's orthopedic surgeries with joint replacement or spine surgery. There's just, between the therapy and the medications, there's just so much that it's vital for the patients to have successful outcomes after the actual surgery.
What we started with something that could be universalized. To make something simple and universal is so hard. You imagine having a team of people racking their brain for 4-year brains just to try to figure it out. And I really do think we're on the precipice of something big here. And like I said, it's one thing when you sit with some of these other companies or providers, or, they want to, their goal is just to hit new macro levels or HEDIS scores or whatever it is. And then you sit with our best customers get it. It's about behavior and love the idea of behavior change and believe it's about habit. It's a different thing when you're working with the care team and nurses who get that. So we also train all of our customers in habit coaching and go through a habit curriculum with them and train them on all this stuff. So they not only does the platform make it awesome and simple for the patient, we try to make it super simple so that you can monitor 100 patients super fast. It's like going through Instagram for our coaches, and they're like super, and then they could chat, and then the chat is dynamic, audio recordings, video recording, emojis. Adding delight is critical on both sides. So that's the whole thing for us. That social plus celebration, combination to increase the dopaminergic effect for every single engagement.
Yeah, it makes so much sense. Now, I imagine there is just big cost savings for these health systems when they're using your technology versus what they're doing now with their more laborsome manual processes to monitor these patients post surgery or post ER visit, and the remote, monitoring in general. Just you must be offsetting a lot of big overhead costs for these groups and practices.
Absolutely. And like we said, if you look at it, there's our two use cases. It's transitional care and then chronic care. So assume chronic care is post 30 days, right? So now, but you're using the same tech and the same team. You don't need to switch anything. But in transitional care, we're going to reach out to the patient even more. So reducing length of stay on average at community hospitals in the United States is 5.4 days and has not changed in 20 years. We want to change that. And Dr. Aguirre at his process before, he would reduce length LOS by 1 to 1.5 days on average. When we were at KP or Kaiser Permanente and some other places, we were averaging a 23% reduction in readmissions. Imagine combining those two together. So if you look at the cost to hospitals on the savings that we're performing for both length of stay and readmissions, it's significant.
And I can see your technology being very useful with the shift to value-based care programs.
Absolutely. I mean, BPCI as an example, like bundle payments, is embedded as part of the core of one of the value-based systems out there. Of course, you have, the ACOs went into that direction, the insurance companies, the self-insured, but like you see that everywhere. And like I said, we talked to 5 different doctors till we selected Dr. Geary to join us. He's a handful. There's like 10 of them who are experts in BPCI and bundle payments. And he implemented that way back in when it first started with the Medicare innovative initiatives, and they show BPCI numbers and impacts and ROI. So taking all of that, we can give you hospitalists if you want. We can manage the entire transitional care program if you want. Or you could just use our coaches and you use your doctors. Or if you want, you could use your coaches and your doctors and you just use our tech. We had to figure out both the service offering alongside, because as much as people want to make it a pure tech solution, it's not. And so when we say we're a behavior AI company, we are not a behavior artificial intelligence company. We're a behavior augmented intelligence company. There's a human element that you cannot forget about in healthcare. You can apply that to algorithms on Instagram till you're purple. But when you're sick in the hospital, there's a human touch. Connection is deeply important. And there's a direct correlation between connection and speed of connection with trust.
Yeah, I mean, I think you made a great point there about the human touch, and especially, with dealing with these patients that have chronic diseases and have been dealing with them for a long periods of time. They don't want a robot to help them get on track, right? Like they want to know there's an actual person. And having this app is also not only satisfying their needs on a health perspective, but it's also satisfying an aspect of socializing
Exactly.
and having a companion.
And like we said, it's multiple things move people. So we many times use one carrot to move behavior. No, we got 3 carrots, 3 core carrots at Vianova today. A year from now, we'll have 7. And where part of the where the AI, the true AI, not just the augmented piece comes in, is you need to use technology to personalize. That's where technology comes in. And you got a part of the personalization is identifying what drives you. We have different drivers that move people. And some people do the human connection because they want the connection. Some people do it because they just need accountability. Some people actually do it out of guilt. I feel bad. And other people, as an example, might do it like we have this whole thing where we're playing with, oh, the coach gets points if you do the job. And so some of our patients feel like they're givers. I'm helping this nice coach. He's awesome or she is awesome. And every time I take a picture, he gets points.
Yeah.
So you're trying to experiment to see which driver moves which person. Yeah.
Some people's biggest reward is to give.
Exactly. And you'll be surprised what 3 carrots work for you might not work. Only 1 carrot is needed for somebody else as well.
Yeah, right now for all my habits, I just throw them all in Google Calendars and I get my reminders. But it sounds like I need a Vianova to help me even develop more on the habits that I've been working on.
I mean, we'd love to be able to work with you. We're trying to.
Well, listen, I know you're a busy guy and you have a lot of things going on. I really appreciate you taking time to chat with us today. You really opened up my point of view on the really underlying issue with chronic disease in America and other parts of the world, which is poor habits.
100%.
Poor habits.
Let me give you a data point. 50% of patients stop taking their meds or what was prescribed to them by the doctor within 30 days. 50%. And I could send you both those studies. Now imagine just that. Just take that one data point and talk about what type of a behavior problem we have. Now, Duke Center of Behavioral Economics says 45% of the decisions we do every day are habitual. So again, I really do believe at the centerpiece of everything, healthcare is a habit problem. And if that's the one lesson you get out of this talk, and we could spread amongst the digital health community, let's do that. Let's make this a behavior thing and not just a medicinal or a technology or a device problem. It's not a device problem. It's a behavior problem.
Sure. And, a lot of providers tune into our podcast. So I think this will really help open up their eyes to how they can integrate more behavior tools like Vianova AI to help better serve their patients.
Absolutely. And we're here to help. So whatever you need, we're here to support the effort.
That's great. Thanks again for your time, Farhad. We'll be in touch and I'll definitely circle back with you in a few months to see what's happening over at Vianova.
No problem. I appreciate it, Elliot. And congratulations on the podcast. Love to see what you're doing. And I hope the Macallan group just takes off. So
awesome.
thank you.
Yeah, it was a real pleasure. We'll be in touch.